Good evening, ladies and gentlemen. A very happy new year to you in the year 2020. Welcome to our new series of webinars which we have on hormone dysfunction in PCOS. And these two webinars which we will have in the months of January and February. The first one is today, that is on the 17th of January. And the next one is going to be in February. We'll get you into date soon. We all know that PCOS is a very common disorder in reproductive age women, which is associated with various manifestations, and therefore women present with different phenotypes. Those women who have oligoamenorrhea or anovulation have a problem with infertility. And to manage their infertility, we do have to carry out ovulation induction so that they can achieve the desired result, that is to have a baby. And we know that when we do ovulation induction, the commonest or the commonest methods we follow are the ones which normally are mentioned by the various guidelines. And we've recently had the international guidelines in 2018 recognized both by ESHRE and ASRM and created by CRE PCOS and Monash University. We all say that the first step of ovulation induction is using ovulogens or oral ovulation inducing agents. And if that fails to work, then we go to the next step, that is using gonadotrophins with or without intrauterine insemination. And of course, the next step, final, would be assisted reproduction if we are still not able to get our patients pregnant. With ovulation induction and PCOS, there are many nuances, there are many tips and tricks, there are practical issues. And who else can do a better justice to this than the world leader in reproductive medicine who's with us today? We have been fortunate enough to have with us Professor Bart Fauser, who is the world leader in the field of reproductive medicine. And he is the person who's the professor at the Utrecht University in Netherlands, and his expertise is related to reproductive endocrinology, PCOS, infertility, reproductive aging, adolescence, ovarian physiology, molecular reproduction, and pre-implantation genetic diagnosis. His research interests are pathophysiology of human reproductive function. We have the reproductive function, the pathology of PCOS, ovarian insufficiency, management of ovulation induction regimens for both anovulatory infertility and also assisted conception treatments. So welcome to Mumbai. We are in Mumbai and we feel you're right here in Mumbai with us. And Professor Bart, it is always a pleasure to meet you and see you. You truly are a great combination of a brilliant speaker and a vibrant personality with an in-depth knowledge of PCOS. We are all looking forward to get mesmerized by you and your deep voice, which can really keep everyone enthralled for a long, long time. We request you to speak for approximately 25 to 30 minutes, following which there'll be an interaction with the global audience. And that global audience will have questions which they will put into a little box which will be on the lower part of the screen. And when they enter the questions there, we will be able to answer your question. I mean, we will be happy if you answer them. So over to you, Bart, and you can start with your lecture now.
Thank you so very much, Professor Shah, for your kind introduction. Yes, although I've been several times in Mumbai over the years, not on this occasion. I'm sitting behind my desk at home just to see whether I can get everything to work. Can you see my first slide?
Emeritus Professor Bart C.J.M. Fauser. Am I right?
That's correct. That's correct. So you can see the slides, everything all right? You can hear me well?
Yes, we can hear you well now, and the slides are good, and you can start.
Okay, very good. Thank you very much. Thank you to all my friends and colleagues from India especially, but I presume also from other parts of the globe. Um, I've been asked, as you probably know, polycystic ovary syndrome is a condition that has had my attention for quite some time, decades, I'm afraid to say. And very particularly ovulation induction has been one of the areas. So I'm happy to share this with you over the next 25 minutes or so. I think it's good to start with disclose my interest. I'm an emeritus professor actually. I'm on the board of the Dutch Medical Research Council. I'm a chief editor of Reproductive Biomedicine Online. I know a journal which is fairly well known in your part of the world. I'm a member of the IFFS Executive Board, and I'm co-chair of COGI, consultant, etc. So a wide range of activities still. Needless to tell you that polycystic ovary syndrome is a very, very common condition. It's still debated whether the prevalence is increasing every year. There is certainly also difference in prevalence in different parts of the world. I would say that depending on diagnostic criteria used and depending on where you are, it is 15% roughly. So that's a lot, you know, 1 out of 6 to 7 women will be diagnosed with polycystic ovary syndrome. So therefore, no surprise that we as gynecologists, particularly, we are confronted with PCOS women very, very frequently. It's good to realize that certainly bleeding, contraception and infertility treatment has been the key focus of attention of gynecologists. But it's good to know that there's much more to the bigger picture of PCOS than what we as gynecologists used to cover. Sexual health, well-being, but certainly also more metabolically driven later life consequences and possibly pregnancy consequences. So of course, in the context of this lecture, I will only be able to cover a fairly small proportion of this focus on infertility, ovulation induction, and to some extent children outcomes. So the outline of my lecture, a few words about diagnosis, because of course it is important. Which patients do you treat and how does it affect treatment outcome? Ovarian stimulation concepts. It seems so very obvious to me, but I still see around me that still many people, and also in many journals, they are confused about the terminology. Then ovulation induction per se and its outcomes, maybe a little beyond the scope, but of course the endpoint of a successful treatment is a pregnancy, but we need to say, you know, just an ongoing pregnancy is not good enough, so we have to look at pregnancies, pregnancy complications, perinatal outcomes, children outcomes, and this is only research over the last couple of years. We've actually been very active in this ourselves, so I'll show you some recent data and then come to a conclusion. So this is, I would almost say, the famous slide of related to a meeting which I organized together with my esteemed colleague and friend, Professor Basil Talatsis from Greece, Thessaloniki, and we brought together at that time the leaders in research in PCOS to try to find a common ground for a diagnosis. I have to say we grossly underestimated that task because it turned out to be much more difficult than we anticipated. But still, I think it's fair to say that it has been a meeting and a consensus statement published in both journals, as you can see, Human Reproduction and Fertility Sterility. At that time, that was novel, so that has never done before. And those two papers became, believe it or not, the most cited papers ever published in reproduction. Over 3,000 citations for each individual publication. So it must have meant something, and indeed, if you look in the papers, still today, most use the Rotterdam criteria, which, and probably needless to say, which focus on it's a heterogeneous conditions. these women are not the same. So there are three major criteria: oligoanovulation, hyperenergenemia. Those were the criteria already present, but what we added was the polycystic ovary morphology as assessed by ultrasound. And we stated that, again, in the light of the fact that this is a syndrome, a heterogeneous condition, that they needed to fulfill only at least 2 out of the 3 criteria. In our field, that was very new, but in cardiovascular disease, that's very common. Most clearly, the metabolic syndrome is like that. There are 5 features, and you need to score positive for 3 out of the 5 to be able to diagnose metabolic syndrome. So it's very similar to other areas in medicine. Now, there has been a lot of debate about this, how valid are these criteria, is it heterogeneous, and what does it mean? But I think a strong point, which I think at the end of the day made everybody accept the Rotterdam criteria, is that there has been a completely independent, evidence-based workshop organized by the NIH in Bethesda in the US, and they came up with several recommendations. It was an independent panel that came, we all had our lectures during that meeting, and at the end of the day, this independent panel of people not focused in research in PCOS themselves came with conclusions. Number one, quite interesting, that they recommended a name change. Several attempts have been there since this 2012, but not successfully, at least so far. But most importantly, remain the broad inclusionary Rotterdam diagnostic criteria. That's the NIH conclusion. And I think the bottom line is, and it's very simple, so you have to decide, do you want to be exclusive, so very strict with your criteria? Then of course you will diagnose a more homogeneous population, maybe even a more severe disease condition. But then how about all these other phenotypes that may look like PCOS to some extent but not fulfill these strict criteria? And Rotterdam is really very inclusive. So we make it broad, that many women fulfill this diagnostic criteria, and then maybe later on, that's also a recommendation, make subgroups within the PCOS, and you see whether they respond different to any intervention. And certainly, as you will see later on, ovulation induction is a clear area where the subgroup analysis seems to be relevant. And just to show you, this is one cross-sectional study performed by us. It's Utrecht and Rotterdam, involving more than 2,000 women that we see in a general infertility practice where PCOS was diagnosed according to the Rotterdam criteria. And here you can see that out of these more than 2,000 women with oligoanovulation, that many of those women do not fulfill the criteria of elevated androgen levels. So this is the women that have ovulatory dysfunction and PCO morphology, so polycystic ovaries. And you see all these women diagnosed with PCOS in our specific situation, condition, they do not have elevated androgen levels, whereas the other 50% does. And again, I will show you later on why androgen levels in the context of infertility and ovulation induction is relevant. So ovarian stimulation concepts, something very, very fundamental, and I would like you to understand, and if you have comments or if you disagree, please let's leave this topic also for later discussion. But the term ovulation induction should be restricted for the medical treatment of anovulation. And you induce ovulation in a woman that does not ovulate to start with. And there the aim is single dominant follicle development. You may say it's an illusion because not often that happens, but that's the aim. Monofollicular development, mono-ovulation, singleton pregnancies. That's what we aim for in ovulation induction. And now, and that terminology has changed. Now the other form is referred to as ovarian stimulation. There, under these women, usually they have normal menstrual cycles, so they do ovulate. So with ovarian stimulation, the aim is to intervene with monoovulation to induce multiple ovulation. And why do we do this, and under which circumstances? This is another way of looking at this. Ovarian stimulation, we do that in the context of IVF, because if we have more oocytes to start with, we have increased pregnancy chances. We all know that in the context of IVF. We do that in the context of IUI, or unexplained ovarian stimulation, widely used over the world. But ovulation induction, again, we restrict that to anovulatory women with the aim to induce monoovulation. And why is it so important to make a clear distinction here? Because under these circumstances, if you stimulate the ovaries in the context of IVF, we can do that without the risks of multiple pregnancies. And why? Because the prevalence of multiple pregnancies is only determined by how many embryos you transfer. Whereas in these in vivo conception circumstances, certainly if you do hyperstimulation with or without IUI, there, of course, the prevalence of multiples is not controlled. So the more oocytes you generate, either intentionally in the IUI context or unintentionally in PCOS, the higher the chances are for multiples. So this is a very fundamental difference in vitro conception and in vivo conception. So in the context of infertility, it's interesting to see that how we do the workup today, and certainly how it influences ovulation induction strategies. And it's actually very simple, and it goes back to initial papers published by Insler and Luneveld. It goes back to 1972, where they say, you look at gonadotropins and estradiol levels. If they're both low, hypo, and then it's a central WHO1 condition. If gonadotropins are high and estradiol is low, it's WHO type 3, so premature ovarian insufficiency, if you wish. But the great majority of patients with they have FSH and estradiol levels within the normal range, referred to as WHO class 2. And of course, dependent on the criteria you use, the great majority of this WHO2 is diagnosed with PCOS. And ovulation induction strategies are relevant under those circumstances. Again, a very fundamental, very old principle, which I think is still very valid today. And of course, in the context of this presentation, we particularly talk about this. Throughout the 19th and early this century, we have been doing quite some studies on classical ovulation induction treatment strategies, with clomiphene as first line, gonadotropins as second line, and IVF as third line. And I think also for later on, for the discussion, we may zoom into ovulation induction strategies versus ART versus IVF. How does this balance out with what we know today? But again, this is what we have studied, and I think it's fair to say that we've been doing very thorough studies with prospective cohort follow-up. So PCOS patients following this algorithm, how do they behave during treatment? I'll get back to that later. And then now the number of different preparations that can be used for ovarian stimulation is increasing constantly. Now there is a lot, I don't know whether you've seen it, it's still in a sort of a phase 2 clinical, the kispeptin, the GPR54 receptor interventions, it can both be used to suppress and to stimulate the hypothalamic GnRH secretion and therefore gonadotropin release. Now, we have the GnRH agonist, antagonist, all sorts of preparations about gonadotropins, now with recombinant urinary FSH, LH, HCG, aromatase inhibitors, letrozole, I get back to that later. And what this compound does, it reduces aromatase activity. In other words, it reduces the conversion by granulosa cells from producing from androgens estrogens, and therefore by aromatase inhibitors you have less estrogen, less negative feedback, and therefore you stimulate the system. Then of course the more classical interference with steroid feedback is the anti-estrogens clomiphene citrate, but there's an increasing number of other compounds, insulin sensitizers, androgens, growth hormone, more in the ART area, but also it's being used in the context of ovulation induction. This is the second PCOS consensus organized by the two of us, Professor Talaxis and myself, this time in Basil's hometown. And I think when we look at this, it's good to put it in a historical context. This was published in 2008, again in Human Reproduction and Fertility Sterility. The consensus there was that we should focus on pre-treatment strategies, so not rush to interventions right away, but look at it from the periconceptual care point of view. The more we do to improve health of women before they conceive, the better it is in terms of reducing complications and improving perinatal outcomes, especially diet, exercise. First-line treatment, clomiphene was recommended at the time. Second-line treatment, either laparoscopic ovarian diathermia, so ovarian surgery, or gonadotropins, and third-line IVF. This may seem pretty conventional now, but indeed, don't forget this consensus now is 13 years old. Ovulation induction outcomes. Yes, let's start with and Professor Shah already referred to this, the international evidence-based guidelines. It was led by Helena T from Monash, quite an amazing enterprise, where so many different countries, societies, scientists were involved to reach a global consensus on various aspects of PCOS. And at that time, the conclusion was that letrozole should be considered first-line treatment rather than clomiphene citrate. The aromatase inhibitor, I will not go into too much detail. Of course, this is developed over the last couple of years. There has been some difficulties around this preparation. Of course, it is off-label use. And therefore it's not available in some countries. So with some restrictions and with a level of evidence which is not so very high, still the people involved at the time considered it evidence enough to say letrozole should be considered first line. I'll come back to this later. To back up this statement, this is a very, very recent paper published in Human Reproduction Update in December last year, so it's just a month old, where they did an IPD, an individual participant data meta-analysis. I'm not sure whether all of you know what this actually means. You know meta-analysis, that's where you bring the conclusions from different studies together. With an individual participant data, what you do is you approach all the authors of the papers and say, can we have your data? So there we don't combine the conclusions of the papers, we actually combine the data of all the papers. And we reanalyze all this data. Of course, a pretty powerful approach. And there, again, the conclusion was this meta-analysis that when you take letrozole versus clomiphene as first-line treatment, both in terms of live birth rate and in clinical pregnancy rates, there is an improved outcome, with an odds ratio about 1.4, as you can see. Now, when you focus on live birth, it has to be said that there's only 3 studies, and therefore the certainty of the evidence, the grading, is still moderate. So we have to be aware of this, that it looks okay, but still the evidence is not so very strong yet. Then, going back to the history of ovulation induction, not everybody is aware of the history of the compound that we still use a lot in infertility care, clomiphene citrate. It is wonderful, and I digged into the history of this compound, and I described it at length in the reproductive endocrinology textbook, the Yen and Jeffrey textbook. Number one, it's a beautiful example of serendipity. This is not how the compound was designed. It was designed in the context of endocrine benign disease. Here, if you look back at the initial papers, it was tested in cystic mastitis, breast cancer, endometrial hyperplasia, or endometriosis. And then just by coincidence, by serendipity, they found that quite a few of these women were anovulatory and started to have periods again. So it's composed of a mixture of compounds, both the ZOO and cis compounds, with different receptor affinity, different half-lives. So in that respect, you can consider it a SERM, a specific estrogen receptor modulator. Available since the early 60s, still most frequently used, and when you look at the endocrine more detailed studies, I think it's fair to state that the mechanism of action is still not fully elucidated. We refer to it as an anti-estrogen, but that's a simplification. So there's more to it than that. Anyway, think about it, used for so long, for more than 50 years now. When we looked, this is again prospective cohort follow-up studies, when we looked at our patients, and it's fairly common what you can find in the literature. This is using clomiphene citrate as first line. You see that the cumulative conception rate, the cumulative ovulation rate is fairly high, 170 or 75%, but the cumulative live birth rate is significantly lower, 38%. So there is a gap between ovulation and pregnancy, but also it's fair to say that if you start with treatment after 1 year, only at that time around 1/3 of patients get pregnant. And of course, if you think about efficacy, that's not so very effective, isn't it? You need to wait for a year to find out that 2 out of 3 of those women underwent the treatment without the desired effect. So we did, and forget about the details, if you're interested, this is all published. We did multivariate analysis. So we looked which factors affected actually the chances for ovulation in clomiphene citrate. And here you can see, I'm sure you're aware of this, a ROC curve, a ROC curve. It means you have a test and the condition. And here the test is the PCOS features. The condition is, do you ovulate, yes or no, on clomiphene citrate. And there you see that LH is of no predictive value. So it's like tossing a coin, whether you have elevated LH, yes or no, it doesn't matter. When you have elevated free androgen index, so elevated androgen levels, yes, there is a predictors. In other words, if you are a woman with higher androgen levels, you have a greater chance of not ovulating when you use clomiphene. And then you develop the prediction model. And we try to individualize this, and you can see that's a whole series of papers by one of my PhD students, Robert Imani at the time, where based on these factors, age, body mass index, cycle history, and free androgen index, you can on an individual basis first calculate the chances of this woman to ovulate and then for her to have a live birth. I think a nice approach in aiming to individualize rather than having the same intervention for everybody. And I think directly and indirectly, this is backed up by others. This is, for instance, a post hoc analysis of Rick LeGros' consortium, Reproductive Medicine Network, US investigators, where they also looked at predictor of pregnancy in women with polycystic ovary syndrome. And their conclusion was free androgen index, BMI, pro-insulin, and duration of attempting to conception were most important predictor. And I think it's beautiful. They made a figure like this with colors. So red is bad, of course, green is good. And we know this type of approaches in cardiovascular disease. So they have the Framingham risk score, which means that if you're at 50 or 60, you can calculate your individual risk for cardiovascular disease in the next 10 years. So yes, there is some sort of validation. And there are other studies to back this up. 2 very important studies published in the New England, again from this Reproductive Medicine Network, put together by Rick LeGros. And both these studies published in the New England Journal of Medicine. Study number 1 was a 3-arm randomized controlled trial where they compared clomiphene as first line, metformin as first line, and the combined clomiphene-metformin treatment. And I think very clearly showing that metformin as single therapy is inferior. And I think that this changed practice over the world, that people all consider this very important. But another figure which received less attention is where they did a post hoc analysis, and they divided all participants and their chances of a live birth based on BMI. And here you can clearly see that the woman with significantly increased BMI above 35, have a much worse prognosis, regardless which compound you get, compared to women with a BMI below 30. So it's not just that the compound influences outcomes, but body weight has at least as big an effect on outcomes. A subsequent study, again, the same Legros multi-center study, again published in the New England 7 years later, where they compared clomiphene citrate and letrozole as first-line treatment. And their bottom line conclusion from this study was letrozole is superior compared to clomiphene in relation to cumulative live birth rates. So I think these data are clear. But again, a post hoc analysis was added to the paper and shown in this figure, where they compared women with a BMI less than 30, how did they respond to both compounds compared to a BMI above 40. A BMI above 40. This is really serious obesity. And here you can see that it varies. So the difference between letrozole and clomiphene in terms of live birth rate is very prominent in the very obese women, but is much less prominent in the women with a BMI less than 30. So in other words, we are not sure whether letrozole is the preferred choice for all women diagnosed with PCOS undergoing ovulation induction. It may be particularly relevant in the context of very severe obesity. Then, and I was on a trip, a lecture tour in India, I think 1.5 years ago, and I found out that insulin sensitizers, especially the myo-inositol, is being used a lot in India. I'm not sure whether it's still true today. There is some indication that it may be useful, but I have to say, this is a summary of the studies that I could find to back up the use of myo-inositol as ovulation induction. And I have to say that the studies are there, but the studies are very small. So a really well-powered RCT to show that myo-inositol is better than other first-line treatments is not available yet. So again, we don't know yet, but we have to be careful with firm conclusions. I will not talk too much about gonadotrophin ovulation induction. This has been generated much attention about 20 years ago, now less so. I think it's fair to say that any dose regimen is fine as long as it is low dose and well monitored. This is our data, prospective cohort follow-up study, where we looked at the cumulative pregnancy rates resulting in the singleton live birth. I think that should be the desired outcome with this conventional ovulation induction strategies. And we did this first with René Eijkemans as first author, the red line, and we did a validation. This was Rotterdam patients. We did a validation later on in Utrecht. This is Utrecht patients, prospective cohort follow-up study. So, and this tells us that, at least in our hands, with our patients, we reach a cumulative pregnancy rate resulting in singleton live birth of close to 80%. Close to 4 out of 5 women that we treat in our country with ovulation induction, they have a singleton pregnancy and a live birth. And that's, I would say, it takes a while, but it is an effective strategy, more effective than many of us would believe. Of course, in the past, the focus has been mainly on pregnancy per se. You know, we would all be very proud of ourselves if we would be able to have a positive pregnancy test. But now we understand that life is much more complicated. it is not just the infertility intervention and a positive pregnancy test. We need to look at periconception health, knowing that the more healthy the woman is while she gets pregnant, the less eventful pregnancies will be. So should we do interventions during pregnancy, yes or no, and particularly focusing on insulin resistance and gestational diabetes? How about birth and perinatal outcomes? How about children follow-up and childhood health? And how will this affect? There may be suboptimal conditions during this. How much may this affect adult health? And of course, there is a genetic predisposition, so that is nature, and there's not much we can do about it. But if we could improve pregnancy outcomes and therefore improve future health of these children, of course, that's more related to nurture, and that's where we can act. In the past, and I guess it still is, we still know, even today, that multiple pregnancy rates is clearly associated with infertility treatments, and certainly ovulation induction in PCOS is part of that. This is a review already some time ago published in The Lancet, where we could show that in 2 decades, worldwide, the number of twin births almost doubled, but the number of triplet and higher order birth increased by 400%. And of course, this is related to fertility treatment, and it's not so easy to assess what is the proportion of ovulation induction in these figures. But even now, largely, the problem of multiple pregnancies is solved related to ovulation induction. We believed initially that singleton pregnancies in PCOS would be normal. And we performed at the time a meta-analysis looking at pregnancy outcomes in singleton pregnancies in PCOS. Published, as you can see, Caroline Boomsma is first author, again, Human Reproduction Update 2006. And to our surprise, we could show that even in singleton pregnancies, complication rates are significantly higher. Gestational diabetes, odds ratio 3-fold, pregnancy-induced hypertension, preeclampsia, birth weight changes, intensive care admission, even perinatal death. And we were quite surprised, unpleasantly surprised by these data, but later on there has been of PCOS patients that did get pregnant. 188 of those patients we followed, we compared it with 3,000 controls, and here you can see again that it's not just that maternal complications or pregnancy complications are increased compared to controls, but they are particularly increased in the women with elevated androgen levels before conception. So women with PCOS and elevated androgen levels have significantly higher chances of pregnancy complications compared to PCOS women with normal androgen levels. Neonatal complications, basically, it's the same. Again, this is based on prospective cohort follow-up studies done by ourselves. We also, and this is more recent, we also linked our PCOS database, which we have shared in Rotterdam and in Utrecht, with our national birth registry. In the Netherlands, we are not so good in monitoring our health outcomes, but the birth registry is very reliable. So we linked all our PCOS patients that we saw for infertility with a pregnancy registry. And there we could see, again, and we could confirm that, and this is a totally different type of information as compared to the previous study, but in the ones with preeclampsia, with preterm birth, you could see that particularly the ones with elevated androgen levels are more often abnormal compared to the normal ones. So here we don't compare it with a control group, but we look at the PCOS features, how they influence perinatal and pregnancy outcomes. And we even, and this is just out, EPUB ahead of print in Human Reproduction Update, we even did a meta-analysis of the children. We looked at children, we did children follow-up ourselves. I'm not going to show you the data, but here, when we looked at it in greater detail, there were only 2 groups in the world that studied children outcome in PCOS. This is the Sir Peterman group from Chile, and the Rickler Growth Group, again from the US. So we brought all the data together. You see, you have children all the way from 2 years of age to 17 years of age. We looked at the common features of the different studies. Again, pretty complex analysis, but you can see that regardless of age, already at a young age, both in men and in women, or girls and boys, we see subtle cardiometabolic abnormalities. So then I come to a conclusion based on all this information, and I try to keep it simple. So what would be my take-home messages related to ovulation induction of PCOS? We need to consider 3 different factors: patient factors, patient management, and the context of the patient. And what I mean with patient factors is female age. For instance, if we would see in our infertility practice a woman 40 years of age being diagnosed with PCOS, I think that her management should be different from a woman 28 years of old diagnosed with PCOS. So female age is a determinant for clinical practice. PCOS diagnosis, the diagnostic criteria, I mentioned that earlier, and I showed you the data that particularly elevated androgen levels are more problematic, both in terms of success of ovulation induction, but even if you're successful in terms of pregnancy complications. So other coinciding factors, obesity, insulin resistance, of course, never forget sperm quality, and we shouldn't focus on the PCOS patients only. Patient management, certainly ovulation induction in the hands of some practitioners is much more successful compared to others. So doctor's experience, it's of course also the applied medication and dose regimen, but particularly the intensity of monitoring. If we do ovulation induction, certainly directly stimulating the ovary with gonadotropins, we need very frequent and thorough monitoring of ovarian response to make it into a successful but certainly also a safe treatment. Then lastly, the context. And what I mean by that is preconception strategies. Again, we should focus on the health of women first before we engage in infertility treatment. We should, although that's not very well studied, consider IVF as an alternative treatment modality, especially now in the time where IVF can be with freeze-all and single embryo transfer. So there you can control the incidence of OHSS, and you can control multiple pregnancies. Of course, it's a more costly, more labor-intensive, etc. But we have to, and head-on comparative trials, IVF as first-line, first ovulation induction do not exist. Then we have to consider that it's not just, what we should focus on is how to get the woman pregnant, but also think about pregnancy complications and children outcomes. And last but not least, if we see at a relatively young age PCOS women that are insulin resistant, severely obese, and severely hyperandrogenic, should we focus on pregnancies only? Because it looks like these women also themselves have increased risk for health hazards later in life. And I think that we as gynecologists have to ask ourselves the question, is this something that we should be, in a multidisciplinary approach, should also be more proactive than we are now? And I'd like to close with this. So in the Netherlands, we have the wonderful circumstances that many young doctors are interested in pursuing a scientific career before they enter into residency. And I think that's the major reason why we have been so very active in this area. Thank you very much for listening.
So much, Bart. Thank you so much, Bart, for this brilliant lecture. I've thoroughly enjoyed it. It's really been beautiful. We already have questions coming in whilst you were talking, and I'd like you to answer some of them if you can.
Sure.
One of the prominent points you brought out is that hyperandrogenism, before we start with the treatment, we need to have it corrected because it's going to affect ovulation induction and even early pregnancy. So is there what exactly do you do when you want to reduce hyperandrogenism?
Yeah, that's a wonderful question, and I think a very smart question. I think in general, elevated androgen levels are associated, for instance, with chances to get pregnant and pregnancy complications. That does not necessarily mean that it's directly causally related. And we also know, for instance, that androgen levels are associated with obesity. That androgen levels are associated with increased prevalence of insulin resistance. So which of those factors is really directly related to these complications? I think it's fair to say we do not really know. And therefore, that reducing androgen levels per se, that would solve those problems, I'm not sure. I think we do not know at this stage. I think we should only realize, and I think in terms of counseling patients, that obese women that are insulin resistant and have elevated androgen levels, that their chances of success with ovulation induction are reduced, and that if they get pregnant, their chances for pregnancy complications are increased. So we should do more intense monitoring first.
So there could be lean PCOS who would be hyperandrogenic. As a matter of fact, quite a few, are lean and they are severely hirsute. So in such patients, is there anything we need to do before we start their treatment?
That's a very good question. And to be honest, we have to be careful because indeed there may be ethnic differences. So whether the same would apply for your population in your country, I do not really know. Really do not know. We can only speak about the patients that we have observed, and of course this is whatever 80–90% Western European descent Caucasian population. And
so in short, if I have a patient who's hirsute, who's hyperandrogenic, I could go ahead with the treatment in a lean person with infertility. And I could also, except for the obese ones, probably I could think about asking them to make some lifestyle changes. We need to probably sometimes, if we find them hyperglycemic or insulin resistant, we could put them on metformin or probably inositols if they cannot tolerate metformin. So in short, we would do everything possible to stabilize them before getting them into the INFER treatment. Is that right, Bart?
Yeah, I would fully agree or support that approach, yes. And indeed, we do also, of course, see women with elevated androgen levels and low BMI, the normal body weight. So it exists in our population, but in our population it's rare.
It's rare, okay. We too have a lot of obese girls and obese women. We also have it rare. But what I've found in my own practice is that the lean PCOS are more hyperandrogenic as compared to the obese ones. The obese ones are usually oligoamenorrheic or anovulatory, whilst the lean ones tend to be more hyperandrogenic. I mean, this is the clinical impression I have. I still have to work out the statistics and see the phenotypes, but this is what we find. The other question which has come in is where they ask about when we see an ovary with a lot of antral follicle counts or a PCOM type of picture, sometimes it does not correlate with the AMH. Is there any reason why that would happen? That's one of the questions which has come, where AMH does not correspond to the AFC.
Yeah, good question. I think there is not really a general answer based on science, based on data. I think in general terms, we can only speak about general terms. We know that AMH levels are related to follicle count, and we know there is an increased follicle count and there is increased AMH concentrations in PCOS patients. In situations where there's a discrepancy between the two, I think in the context of ovulation induction and what that means, we don't really know. And for me, the most puzzling part is that we know that follicle count also in PCOS patients, decreases with age. And actually, increase in age may alleviate PCOS features on the ovary, but also menstrual cycle irregularity. And we have the impression, we haven't worked out the statistics, but we have the impression that women with PCOS that are 38 or 40, that in terms of ovarian aging and in terms of chances, it's a different population compared to normal ovulatory women. So there's a lot of information hiding there that we don't really know. And also, how and to what extent can AMH concentrations be used as an ovarian aging marker in PCOS patients? Again, we don't really know because we do not have normative data in PCOS patients over time. There is some publications we published on this, but those are small numbers. But big numbers, PCOS, how AMH develops over time, we don't really know.
Yeah. As a matter of fact, if I have a 40-year-old patient who comes to me, would I ever be able to diagnose whether she was PCOS before?
The severe phenotypes, yes. Still at age 40, there will still be PCOS, but it could also be normalized. Already.
Exactly. Yeah, but probably she would be at an earlier age having metabolic syndrome. Maybe she would be having more of visceral obesity. Probably with that, you would surmise that she may have had PCOS before.
Yeah.
It's so difficult to make out these.
You can only guess. If there's no data, then you have to think rationally and come to conclusions. And it's also because I think it's very important to realize that we now know that age of menopause in PCOS women is later compared to the general population. So you would presume that ovarian aging will also take place less prominent in PCOS women, and therefore a PCOS woman at age 40, she may be more fertile than a normal ovulatory woman at age 40. Again, this is speculation. We don't know, but based on rational arguments, it makes sense.
Yes, absolutely. So coming to the oral ovulation-inducing drugs, we talked about both letrozole and clomiphene citrate. Which one is the drug you tend to use in your practice?
Yeah, but Dutch people in that respect are pretty conservative, and so we still use clomiphene citrate in the majority of cases. And also because, for instance, had the study from Legros showing a letrozole improved outcome. When we looked at our, I think, carefully designed prospective cohort follow-up studies, our clomiphene results are better than their letrozole results. So we could also look at absolute numbers. And with our, as I showed, 80% success rate, I think those are pretty reassuring. And that's for us enough reason to continue with the treatment what we are doing now. But I'm the first one to say the studies so far, including the meta-analysis, show that letrozole should be preferred.
As a matter of fact, some of the guidelines are talking about letrozole being the first drug of choice. But because it's not available in all the countries, not yet FDA approved, many people do not use it, especially in the US. What about the Netherlands?
It's available in the Netherlands, but like in some other countries, it is off-label used. And a couple of years ago, the pharma company that sells letrozole in the Netherlands, they wrote a letter to all gynecologists, basically prohibiting us to use that compound in the context of infertility. So if we now could do it based on new evidence, with this letter in mind, you may put yourself at risk if a problem occurs, which might happen in terms of liability issues and legal implications. So certainly in my country, people are still quite reluctant.
As a matter of fact, we had a situation here that at some point in time, it was not, approved for use, but now it is approved, and all of us are using it, and we are finding very good results with it. As a matter of fact, So there's the next question is that women who have a high basal LH on second day of their period, when you are carrying out ovulation induction, is there any particular choice you have of what product you would use or what protocol you would use for ovulation induction?
Yeah. Now, based on our own data, where we use the algorithm as shown before, whether a woman starts with treatment having elevated LH levels or not is not relevant. It's not affecting outcome.
Okay.
And also what I see, because many people still believe, I think based on data from Britain, Howard Jacobs group a long time ago, that elevated LH levels was associated with increased miscarriage rates in PCOS. And that would be the reason for interventions. That too, I think in more recent studies, that cannot be confirmed. So most studies show today that miscarriage rates in PCOS patients is not associated with elevated LH levels. Okay. So no, in our context, we do not change our medical practice, but that's related to the exact mechanism of action of clomiphene citrate is not so very clear, because we see when you monitor clomiphene stimulated cycles more closely, you see that LH levels rise in the follicular phase. And of course, in women that has elevated LH levels to start with, and which will rise even further, you could speculate that may not be so very favorable for outcomes. But again, as far as I know, this has not been well studied.
But could it lead to sort of a premature LH surge, or sort of, could that be a reason for her not conceiving?
In theory, that could, yes.
So probably if she does not respond to oral ovulation-inducing drugs, then probably one would tend to use or go into IVF with gonadotropins and antagonist or agonist, depending on whether you want to prevent the premature LH surge.
Yes.
So question is, if you are constantly getting a premature LH surge, it probably would entitle you to use assisted reproduction to prevent the premature LH surge.
Exactly. Yeah. And then maybe start with co-treatment to suppress a further rise in LH at an earlier stage than you would normally do.
Yes, absolutely. There's one more question which has come in, which talks about metformin, and whether you use metformin in all your ovulation induction cycles, or would you like to use it only in those who are obese or showing some form of hyperglycemia?
Yeah, here again, we have been fairly conservative and fairly restrictive with the use of metformin. We are aware of the fact that certainly in the US a while ago, every patient was treated with metformin before pregnancy, during pregnancy, after pregnancy. So we don't do much of that. But I have to say that also we live in a country where also the prevalence of obesity is increasing, but is still much, much lower than you see in the US and some other countries. So no, metformin is not so much used in our country. There is a major focus on diet and exercise rather than medical interventions.
Yeah, I think that's very true. But then there are many women who are just not able to lose weight, and if we keep waiting for them to lose weight, probably we'll miss the bus with their age.
Yep.
So I think we need to take sometimes. There was a very recent study I read where they compared a group of patients. I'm forgetting which journal it was in, but they compared a group of patients whom they immediately started treatment, even though they were obese, and the controls were patients, and other group patients subject to lifestyle changes followed by assisted reproduction. And what they found is that when they compared the two groups, the ones who had not undergone any lifestyle changes did better than the ones who went through lifestyle changes. So the conclusion of that study was, even if she's obese and she's not able to lose much weight, you go ahead with the program with your treatment in terms of assisted reproduction, because then you do get your results sometimes, probably faster than you would get with them.
I understand, and I hear that more often, that point of view. On the other hand, I think it's not only our responsibility to get these women pregnant, but focus also on pregnancy complications and the health of children. And I think there's no doubt that improving health by reducing weight and insulin resistance will decrease pregnancy complications and improve perinatal outcomes. And indeed, it is clear that, you know, for us as a gynecologist to just tell a woman, you know, that it would be good to lose weight for obese PCOS, that's not very effective. So you need to organize, be very proactive, organize, have psychologists, social workers involved, bring these people together and let them feel that it's a group effort, that they help each other. What we know now, also from studies, that when you organize these kind of activities around this, that it's much more efficacious
Yes.
than just, you know, sitting behind your desk and saying, you know, you should lose weight, because that's not new. They already knew that, so they sometimes just feel offended by us just saying that again and again. So that's not very helpful.
That's very true. Very true. So we have a few minutes more left, and there are some more questions. Actually, there are many questions, but I think I'm going to just ask one or two more. The other difference is, they are asking the question mainly about you know, the high LH and the high androgens and the insulin resistance. Question is, how do you balance out all these? If we have patients with PCOS, we find all these problems. Except for lifestyle changes, is there any other suggestions you have?
No, there's only general comments. My general comment is that also certainly you have to take the age of the woman into consideration. If the woman is young, you just have more time. So there's less need for invasive treatments. So if women have all sorts of unfavorable factors next to age, the factors that you mentioned, androgens, body weight, I would say that based on the fact that ovulation induction strategy will be less successful, and you will basically waste time, so that these women will get even older and with a poorer prognosis. So I would be in favor of giving these women the benefit of the doubt and start with ART earlier, if it's a possibility for them, of course, financially, etc. But in that respect, these factors would alter my patient management.
Yeah, absolutely. Do you all ever treat your patients with bariatric surgery in case she's not able to lose weight prior to assisted reproduction?
Yes, it's being done. It's actually being done increasingly in my country, certainly not in the context of infertility especially, but just in general. And yeah, what to say? I think in the context of infertility, you have to be very careful. Very careful that we know now that metabolic derangements after bariatric surgery are very common. We know now that you have to wait at least a year after surgery before aiming for pregnancies, just from a metabolic point of view. But I think it's fair to say that there are not many studies to do the proper follow-up in a significant number of women. We only have basically small extended case series in the literature. Bigger groups, I'm not aware of any publication looking at their fertility, you know, which proportion of these women will gain normal ovulatory cycles and will be able to conceive spontaneously. How do they respond to ovulation induction strategies? How about additional complications during pregnancy? I think it's fair to say that now we see, in the beginning there was a lot of positive feelings towards this approach, but the more experience is gained in general in bariatric surgery and what happens with these women after undergoing this, I think there's more reluctance and more room for reservation and be careful with doing this.
Yeah. Okay, the last question I will ask you about is that we believe that in PCO patients there could be issues with endometrial receptivity. And today there are those tests available like an ERA test, which is for endometrial receptivity assay. Would you like to use such assays in such patients where you find implantation is an issue?
My honest answer would be no. I don't think that there's a rationale for doing this. I think gene expression in endometrium, how it relates to and how it effectively changes patient management, not everybody is convinced at all the benefit of such a test. But particularly in the context of PCOS, convincing studies showing that looking at gene expression profiles alters your patient management, and by doing so you will improve implantation rates or improve live birth rates. I don't think those studies exist, and therefore I think that we should be cautious with introducing such tests.
Absolutely, absolutely. So I think there are too many questions, and probably I would not like to take too much more of your time. We'll thank you very much for being with us today, Bart, and truly enjoyed your talk and your discussion. And we look forward to meeting you again, hopefully at Eshrei,
yeah, for sure,
or wherever else in the world. And if there's anything you could advise us on to the PCOS Society of India as to what we could do. We are very keen on doing research, clinical research, and we need mentors like you to help us in carrying them out. So we will get in touch with you to assist us in these programs, and look forward to seeing you again. I'd like to take this opportunity to thank Professor Bart and of course and all our viewers globally who have been online. And we will also like to thank Impure for helping us or supporting the logistics of this meeting. So till the next meeting, we will like to announce what meetings are in store. After this, we will be having the next program coming up by Nicholas Panning on the 12th of February 2020, who will speak to us on abnormal uterine bleeding in PCOS. The next program we have is, please block your dates for the 2020 annual PCOS conference, 7th, 8th, 9th August 2020 in Bengaluru, and we hope to see you all in large numbers. We will be very soon putting up the program on our website. We also have the expert program or the online course available to you. These are 6 modules on PCOS and assisted reproduction. And this program is available free of cost to all those who log in and can access this program. But the certification for the same is available only to those who are PCOS Society members. We will be utilizing the same modules for the online quiz, which we are planning to have in the month of April, May. And these will make you eligible for appearing for the live quiz at the annual conference. So, ladies and gentlemen, thank you very much for being with us here today. And you could watch everything. This program will be archived on the PCOS Society website once the editing is done. And we will send you a copy, Bart, of the edited program. Thank you very much, and a good night to all of you in India. And probably good afternoon to you. What's the time in there, Bart?
It's around 5 p.m.
5 p.m. is not bad. You can go and have your dinner. Thank you so much. Okay?
Thank you very much. It has been a pleasure joining you this day. See you soon. Bye-bye.
Bye-bye.